Yeah, I think we can hear you, Saibal.
Well, we thank you for this late hour and your expertise, and we'll turn it over to you if you want to explain what's happened so far and where you're at. But we've explained a little bit the procedure to the audience, and
Yeah, so we really don't want to waste any much time, but we're going to tell you because while we've gone, what happened is this is a patient who was being considered for coapt, but the patient his EF has dropped to less than 20%. It's 15 to 12%. Has had 6 admissions of heart failure, is almost on dobutamine drip and cannot go home. This is being done on compassionate grounds, and that's the reason why I'm showing this case. So I'm not going to show any pictures. To go off the PowerPoint, we just showed you, you saw it's a functional MR, a very wide jet, a malcoaptation leaflet, and Moody showed you the picture. So can you show a very wide jet with a malcoaptation of A2, P2. Do you have any questions about it?
no, we've gone over it. There's one predominant jet, but there's a secondary jet, and kind of broad-based. Do you think this will take 1 or 2 clips?
This will be at least 2, 3 clips, maybe 3 also.
That's what we thought too.
So yeah. Now what we have on the screen is we have a LA pressure simultaneously being measured. Can you show the screen, the the pressure screen? Hemodynamic screen? Can you show the hemo screen? And you can see that's the LA pressure. We measure simultaneously LA pressure during the procedure, and we are going to demonstrate to you that when we grasp the leaflets, we'll actually show you a reduction of LA pressure. So the LA pressure starting was around 34, it's dropped to over 28, and a very prominent V wave. So we're going to, now as you know, we've advanced the clip delivery system and into the left ventricle. And as you guys are describing very nicely that we oriented the clip, we're now below the valve. And now we're going to actually check it below the valve, and we think the orientation is good, right? So I think we're going to now go for the grasp. And because it's a broad jet, we decided to go on the slightly medial aspect of the broad jet. And the person who's doing it is Moody McCarr. He's actually a cardiac. Is the respirator off?
Oh,
Okay, can I see where we are in the jet? Okay, so we're right in the middle of the jet. So we might just go a tiny bit more medial, right? To go a little past that. And let's go and explain. And we're trying to... You can see that we've got both the clips very well visualized. These are actually quite challenging to grasp because they're so restricted. So we may take some time to grasp it. And he's trying to bring it over like that. So I close it to 120. Get me ready. Clockwise to guide slightly. And then I'm going to bring the leaflets up, close. And I missed the anterior leaflet. It's the posterior. That's the anterior again. No, don't turn too much. Turn very little at a time. Turn very little at a time. So these are particularly difficult restricted leaflets. And we're just going to take a little bit of struggle. Okay? We dropped it, we missed it. So, drop the grippers. And you see we've grasped the leaflets. That's a nice grasp. Can you see the leaflets have been grasped?
Yes.
And now and watch now. Can you show LA pressure directly, please? Show the LA pressure and see how it's going to drop as we close the clip. See the V wave has gone away? Did you see that? And we tighten the clip. So even though there's jets all over, but did you notice how the V wave has gone away on the LA pressure tracing? And so we have a system now. So we're going to check everything systematically. There's a medial jet, there's a lateral jet, but I think we're going to keep this, right? What we're now going to do now is, have you noticed that the LA pressure came down? Can you hear me there?
Yes, we hear you great. Excellent.
So what we're going to do, you agree that we should keep this clip?
Yes, it looks like it's pretty good. It's actually a pretty good result. It's not perfect yet, but
Yes.
They may want to move it.
And now you can see by echo, we've already got a very nice graph. See that leaflets are in? Right? So now what we're going to do is that leaflets are in. Moody, you agree with that, Moody?
Yep, I agree.
Moody is a cardiac anesthesiologist, and he should be taking credit that he's doing all the echo by himself. He's doing anesthesia as well as the echo. Now we're going to do systematically the gradient, the mitral gradient. So the gradient is nothing. Okay. Next we're going to see the pulmonary vein flow. So the gradient is less than 2. So we're going to... So that's the pulmonary vein flow that we're doing. Now it was completely reversed before, and now you can see it's just blunted. Before it was actually systolic reversal. So, and the same is with the right upper. And then we're going to check the gradients. So that's the right, the same thing, blunted. Now let's see the 3D end phase. And now if everything's fine, we're going to deploy this one. But this is a new thing that we're doing is we're monitoring pressures, left atrial pressures while we do the procedure. Okay, so let's see the graph. And you can see that we've grasped the medial part of A2P, which is usually where the jet is, and then we're going to put a second clip either laterally or medially. What do you think, Nate? Do you like it? Yeah. So I think we're ready to grasp. Is that okay, you guys? You should deploy the clip. Go ahead. One minute. Wait a second. So we're getting a nice view to see where. What do you think? Okay. So we can see the clip in our fluoro, and we're going to force the clip open. Yep, so open. So you can see it's trying to force the clip open. Okay. Tighten it up. Is it quite tight? Let me see. Okay. And now do it again. Okay. So we are going to put a clip just lateral to this one. You guys are ready for the next clip? Any questions from the audience while we're deploying the clip?
Can I ask a question?
Yes.
Hey, Saibal, this is Manny. Can you hear me?
Yes, Manny, I can hear you.
So, question. I understand that clip is a little medial, which makes sense. But since you have two jets, one medial and one lateral, and both of them look reasonably significant post first clip, would you move that clip a little more medial so you give a little more chance at the lateral? Or would you leave it where it is and go for the lateral? Because it's possible that you may still end up with a medial jet, which may be significant.
Well, if you look very carefully at the medial jet, it's actually coming from the medial commissures. It's not from, because the clip is actually in the medial part of A2P2. So we are going to definitely fix the lateral jet.
Okay.
Okay? Now the reason why I deployed the clip is for two reasons. One is that we did see a reduction of MR, right? Both hemodynamically and by color. It was a very difficult grasp,
Understand.
as you can see. And so we don't want to let go of very good grasp.
Okay. Thank you.
So now, see, once the leaflets are stable, it's going to be much easier to put a second clip close to the first clip. So we expect that we're going to take care of the lateral jet, and we may be left with a small medial jet. But if you look at the medial jet, the pizza below the medial jet is quite small. So we are actually happy to do that.
Moody, can you confirm it has leaflet attachment again? Leaflet attachment again, before you pull the gripper line? Yep. I think leaflet attachments are very good
Take the cover
here.
off. The leaflets are still well attached. Very nice. So let's take this out. And so we're going to be ready with the next clip. But the LA pressure has dropped already, as you can see, from 34 in the beginning, 28, and now it's only 18. So obviously we made a difference, right? Can you show the LA pressure? Can you see that? Before it was 34, 28, and now it's only 18. How much of guide do we have? Can we see the guide?
Show short axis, please. for the
Show you the guide.
And for the audience, you notice how they're doing a lot of what's called color compare, where the left-hand panel is the 2D and the right-hand panel is color, and they're doing a lot of biplane or X-plane imaging. Both are very helpful.
And, a comment on these type of
You
cases.
don't have much guide.
Okay, these are complex cases to start off. Even for, I mean, these are fine in expert hands. But if you're starting a new program, these are not the cases you want to start off. Again, this is most of a LV dysfunction case. But for a new program, stick to A2, P2, degenerative, simple cases, at least for the first 20, 25 cases, before you take on the ones with severe tethering.
Oh yeah, these are very difficult cases. These are actually patients who were never included in any study. His DF now is 12%. He's actually trying to be on the transplant list. He's in refractory class 4 heart failure, and I actually had a different patient that I was doing today. But because he's in refractory heart failure, the heart failure people told me to do this case. So I switched the case and I'm doing this case. So, okay, did you increase the pressure up?
Yeah, so his pressure is improved from 90 to 115.
150? So
One- one-
another thing that
115.
the anesthesia just told us that his pressure was 90 by 60 when we started. After the first clip itself, his this thing has gone up. So just go back to echo. His aortic pressure has gone up already after the first clip. And that's usually a very good sign. Tarun and Dave are actually interventional fellows, and they become so good they actually do all the procedures by themselves. All right?
Hey, Saibal, can I ask you a question for discussion?
Sure.
So what's the acceptable gradient that do you have a threshold for your gradient before you decide on the next clip?
Less than 4.
Thanks.
Moody's 3D steering.
So we're going to show you how we steer 3D down straight using, so he's going to show you the 3D volume, full volume, and then you can see the valve. That's the surgical view. And then we're going to turn down over the valve down. Yes, bring it down. Okay, get down. A little bit more. Okay, good. And then turn it down a little bit more. And that's enough. Good. Perfect. And a little bit of clockwise to guide, and you're ready to go. And usually we do a little bit of RAO. And the advantage is fluoro at this time is you just have to be parallel to the first clip, and then you'll be okay. So a little bit of air, that's enough. One. All right? And then we just pull the system back a little bit. And now go to BICOM LBOT. So we do bicommissural LBOT by explaining the zig. And see, we can see that we are right next to the next clip, and we're going to explain that, and it looks great. We're already there in a nice way, and then we just clockwise the guide, and I think we're all set. So we can open the clip now. Can you see how we are lateral to the clip? And just open the clip. Good. And open the clip, right? Good. 3D, and lock the clip.
3D on
And now we 3D end face, and we want to see the orientation. And you can see this orientation of the clip is perfect. It's like exactly 90 degrees, perpendicular to the line of coaptation, maybe a little bit off, and I'll just turn it a little bit down here, up and down. And we are ready to advance. Now, when we do a second clip procedure, it's very important to hold the respirator because the clip keeps moving, and you should advance the clip closed. So let's go back to BICOM. And let's get a nice view simultaneous. And let's put the color jet on to see where the jet is. And let's now
Want the ventilator off?
ventilator off. Okay, so now let's see the where we are in the jet. Close the clip. So we're going to close the clip, Good. That's great. That's enough. And now we want to see whether we are in the jet or not. So you can see that, get the color off for a second. So I think we are, and we take a little bit of M off. That actually makes it one a little bit more further M off. And now we can come back. Is the respirator off?
Is off.
I think we are right in the middle of the jet, correct?
Yeah, you're splitting the jet, as you can see on the screen here.
Very nicely. Okay, good. So we're just going to advance the clip. It goes nice and parallel. Open the clip. Okay. Good. Very good. And Tarun is going back and forth with the guide catheter to arrange it. That looks, no, 180. And drop the clip. Now now we see the orientation below the valve. So let's go back to the surgical view. And then he's decreasing the gain, as you were mentioning very nicely, I was hearing. Okay, a little bit. And make the clip oriented, that's very good. Go down.
You think needs to clockwise it a little bit?
Sorry. Let me show you that you're down. And I'm just trying to orient the clip. Okay, so now let's go to BICOM LVOT. And they're ready to, now let's check with color. Are we in the right spot of the jet? I think we are, right? So what do you think, Modi? Should we go a little bit more medial?
A little bit more medial, yeah. Because we don't want to leave a jet in between the
So
clips.
let's go a little bit more medial. Okay, and we can actually give a little bit of M to it. Close the clip a bit. Let's close the clip to 120. And clockwise the guide. A little more posterior leaflet. Yeah. Clockwise more. Yeah. Clockwise more. So you may have to. Don't is not transmitting. Not transmitting. Not anterior. Then he's not getting the posterior leaflet. That's better. No, still not getting it. Setting 100. Okay. Good. Like that? Yeah. Good. Keep the grippers down. Okay, close the clip. Very good. See the color. Color, please. Okay. And you see that the lateral jet is completely gone. You like that?
Yeah, very good.
That's it. That's like magic. And the LA pressure, have you seen the LA pressure now? Can you show the LA pressure? Can you show LA pressure live, please, Chris? Can you see the live LA pressure? Can you show it large? That's the LA pressure at 12. So remember, we started with 3426, and now we're at LA pressure of 12. And that's the gradient. And you can see over here, the A and E are almost equal to each other in some of the beats, which means that you can't have significant MR, right? If the E velocity and the A velocity are almost the same, it rules out severe MR. Am I right? I'm talking to an echocardiography audience.
You are correct.
I'm trying to speak echo. Not wanting to speak like that. And the gradient's only 1. So let's look at the pulmonary vein flow. You see the little catheter in the pulmonary vein? That's actually the pigtail. Now look at the systolic pressure. Remember, it was completely reversed before. And now for the first time, is actually the systolic and the diastolic are almost same. Do you see that? Do you agree with that, members of the panel?
Yeah, we agree.
Let's go to right upper pulmonary. But to me, the most impressive change is the changes in LA pressure that comes up. So that's what the patient feels. Let's go down there. And look at the flow now. It's a completely different pattern. See that? I think it's predominantly systolic predominant. Is that correct? Members of the panel, am I right?
Yeah, pretty equal, but yes, certainly an improvement.
Equal.
How's your blood
With that
pressure?
year.
Did your blood pressure improve further?
Yes, it did.
It does.
Now, how much is it now?
It's 115.
It's 115 by 60. This is the characteristic thing that we see. We reduce the MR, the aortic pressure goes up instantaneously, then it actually re-equalizes, and the LR pressure drops. And these are very good signs. We think these are most important signs that we're doing, especially in functional MR with such thick heart. And you can see the smoke in the ventricle. It's an EF, which is terrible. And so we've done the gradient. Let's go 3D end phase. And Manny, you agree that there's no lateral jets? So
He agrees.
Manny agrees.
for the first time. And that's the nice double orifice. You can see we've got a nice wide jet, wide tissue bridge, which is obviously stabilizes the leaflets much better now. And you have two orifices on either side. Okay? So we're going to deploy this clip also. Let's deploy this clip. So we want to show you fluoroscopically. We have to get a nice view where we can see the clip. Please, can you see fluoroscopically how nice and parallel they are? And that's what we like. And then we're going to get a view where there's iliocranial, and can you see the clip is well closed now, and he's going to force the clip open. Okay. Not opening. Okay, good. Nate, do you like it, President? Nate, you're so focused on Donald Trump, so. Did you see how the ventricle function is like? And this is probably one of the only technologies that can be done in such low ejection fraction. Surgery, no surgeon would like to operate on these patients. I think transcatheter mitral valve replacement in such low ejection fractions will be a travesty. And I can see over here, there's no lateral jet in the deep transgastric, and there's only a small medial jet medially extending onto the medial commissure. So we may or may not put actually a third clip. I may actually just leave it like this. What does the panel think?
I think the enemy of good is better. I would be happy with what you have and keep the patient on the transplant list.
That lateral clips look perfect to me. It was the perfect spot.
Yeah, I think we got it in the right spot. I think we could have gone a little bit more medial in the first clip, as Manny was saying, and then maybe we could have made a slightly better result than what we got, but we were having challenges in grasping, so we just took what we got.
Confirm a leaflet attachment.
And so the leaflets are well attached. You want to just check. So before we just release the clip, we just want to see that everything is attached. And
Dr.
Will you
Sunil,
explain
can
that?
I ask one question? I'm Rakesh Gupta from Delhi. What
Yes,
happens
Rakesh,
to
how
the LV function finally? Look,
So-
that's what the most important thing. When we started this procedure, we did not
Yes.
see any LV smoke. And once we have completed the procedure, lot many LV smoke is present. On top
Yes.
of that, your blood pressure has gone up. What exactly happens to the LV function subsequently? Because
Yes.
that was one of the
So-
reasons when L-free procedure were given up over a period of time.
actually,
He's hearing
let
your
me tell
question.
you the numbers. There are 35,000 microclips done worldwide, okay? And out of these 35,000 cases done worldwide, as mentioned by the people in the panel, in the U.S. it's only approved for degenerative, and the only way we can put functional is either compassionate or in a trial. But in Europe, 60% of the patients are functional MRs turned down by cardiac surgeons. Now, what we found in these patients, and I'm going to show you today, that unlike surgery, when you do open heart surgery on patients with no function, they go into what is known a low output state. Look at this patient. Without anatropes, his blood pressure is going up because of increase in forward flow. And then what happens is the blood pressure goes down again because the systemic vascular resistance actually goes down. And so what happens is there's an increase in forward cardiac output. There's a decrease in LV volumes, and we have shown even in the Everest 2 high-risk registry, there's reduction in the LV size, both L systolic as well as end diastolic, but the ejection fraction is usually constant. So the ejection fraction, which is, as you guys in ECRO know, is a function of many other aspects other than just size. But what changes is the LV size. And as you know, if LV size reduces, there's a reduction in wall stress. So if you have a reduction in wall stress in LV size, to me, that is the most important thing. Now, I've done a lot of cases in coact, and what I found very impressive in patients in coact is that when they come with us with low blood pressures, we do the mitral clip, their blood pressures go up, and now they tolerate their medications, which they could not. So we found that many of these patients who were not tolerating any ACE inhibitors or beta blockers, suddenly their pressures are higher and they start tolerating after reduction better. So the combination of medical therapy plus the mitral clip in patients with severe LV dysfunction plus MR is actually very beneficial. Now, all the data that I'm telling you is based on observational and registry data, and the trial that is hopefully going to end finally, the COACT trial, will probably answer the question whether actually an actual reduction of MR with the clip plus medical therapy is better than just medical therapy alone. Dr. Gupta, did I answer my...
Thank you very much.
So the question is now, should we carry on or should we just stop here or should we add another clip? So let's look at the medial jet. My thing is that I don't think chasing that medial jet would make a difference. But let's actually explain that jet and see how close it is. And if it's very close, I can put a third clip.
I think it's very insignificant, and the hemodynamic improvement that we got is not.
That's too cardiac output. What do you think? I think the jet is, to me, the jet is so much smaller. What do you think on the members of the panel? We have some very famous echocardiographers over there. What do you all think?
So I think, Saibal, this is a terrific result. I would not do anything about that medial jet.
Ready for cardiac output?
Right.
I think given the patient was so sick, this is going to do a world of good for this patient. I would not do more. I think, and it's going to be hard to fix that medial jet, I think.
Yes.
So,
It will be challenging also.
yeah, and I don't know if the results can be any better than what you have right now. This is a terrific result.
Yeah, when you go on the sides, very medially, very laterally, what happens is you get caught in the cord, and actually you can make things worse. So I'm not very interested in putting in a second clip. But you can see over here, very nice, this beautiful tissue bridge. And you can see the medial clip is on the medial aspect of the A2P2, sparing the P3 region. We can go a little bit more medial, but I still think there'll be always a commercial jet. And then the lateral clip is just lateral to it, and you have a nice double orifice valve, which I think, and it's adequate orifice without any stenosis. So can we do cardiac outputs?
Dr. Saibal,
Yes.
Dr. Amudan here.
Dr. Manthan, thank you for inviting me, Namutar.
You wanted to show one valve-in-valve procedure, and you can show that.
Okay, we have time, sure. Absolutely. So we are just going to finish the cardiac output, and we're actually measuring cardiac outputs as we know. We started with an average of 3.3, and now we're doing cardiac outputs after the procedure. We always do hemodynamics after the procedure and before the procedure, and we're just showing you now. And remember, we never do the cardiac output with the guide catheter out, because if you pull the guide catheter from the left atrium, then you have a big hole, and then you have a left to right shunt, then you artificially increase the cardiac output. So we don't like that. So we actually are being honest and doing the cardiac outputs with the guide catheter in the left atrium. And you can see the cardiac output has significantly gone up. Did you see that? It is now 4.7, 4.9, and we're doing one more reading. So we're very happy with the results because three things have taken place. The aortic pressure went up. So these are the cardiac outputs that have come out. 4.7, 4.95. So, and the initial cardiac output was 3.3. So the cardiac output has gone up by 1 liter. Full 1 liter increase in cardiac output. The LA pressure has dropped, and the mean aortic pressure has gone up. So I think we've achieved all the hemodynamic features that we need in a patient with severe functional MR, whose EF is less than 20%. I don't think any sensible surgeon would be operating on a patient whose EF is less than 20%. His EF is 12%.
Saibal, Saibal, it's Raj here. Can you hear me?
Yes?
Just some couple of questions for discussion purposes. Do you
Yes.
think putting the first clip made it easier, brought the leaflets closer together, and helped you putting the second clip, or it really was totally independent? What's your thoughts
No,
on?
no. Your point was absolutely well taken. As you noticed, that it was much more difficult to do the first clip. And then once you can grasp the leaflets and stabilize them, then putting the second clip is much more easier. That's one of the reasons why I did not want to move the first clip, because it was a challenging grasp, and as soon as I got it, I took it, and then I knew that I'll stabilize it better with the second clip. So you're right. We often do that. We put in one clip to stabilize the leaflet, and that helps the second clip. Absolutely.
The other question, again, for discussion, when you have these cases, and we discussed this, that this is most likely to be a two-clip case, do you typically go right in the middle, see how it goes, or go to one side? What's your general approach, not in this particular case? Do you go to the middle, put a clip, and then decide, or go to one side and work your way through?
So there are two strategies. If you have a very broad jet, as in this case, the right way to do it is probably go to slightly on one side, either medial or lateral. But what happens is, if you notice that when you have a restriction of the posterior anterior leaflet, the restriction is most medially sometimes, when the leaflets don't coapt at all. So what we do sometimes is, we put the first clip where it's less malcoapted, and then we stabilize the leaflets and put a second clip where it's more malcoapted, right? That's called clipping by zipping. That means we zip the less coapted part and then manage to get the more malcoapted part. And that's how we do it. Sometimes I just try a clip in the middle and see how it does. And, if there's two tiny jets on either side, leave it alone. Or if there's one jet larger than the other, I just put another clip on the side. But you're right. If you get a big, broad jet, you should start on slightly either lateral or slightly medial of the middle. And it's preferable to start slightly medial.
Thank you. Yeah, that's probably what we discuss at our workplace too. And do you have situations where you have to go back and plug the transeptal puncture where you had a significant shunt?
So we actually have done our procedure here. We are actually going to show you that. So let's look at the ASD now. And I think if you all agree, we are finished over here. Nate, who's standing behind, and he's very tired after the convention and the debate with Donald Trump.
Are we?
We want to take the guide out. So we have seen that we've had patients who have had right to left shunts. We've had patients who've had desaturated, or the septum is torn and we have to close the septum. So now what we're going to do is, once we finish the right heart study,
All right.
as we're doing now, we're going to pull the guide catheter out. The RF pressure has remained constant and the PA pressure has remained the same. So what we're going to do is we're going to take the guide catheter out from the left atrium, just straightening out the guide, and we're pulling the guide catheter out. You can see we still have that pigtail catheter in, measuring the RF pressure, and that's the hole. And Moody, do you want to measure that hole?
Sure.
And we'll decide whether we should do that. You already took a third clip out. But we didn't do that, right? Okay.
It's about almost 1 centimeter, 0.9 millimeters.
So it's less than a centimeter. So we think we're just going to leave it alone. Can you do a short axis view of this hole? We don't often close those holes. Can you see the short axis again, or 3D?
Oh, you mean the 3D? Oh, okay.
This is now?
Yeah.
Yeah.
That's just a pigtail across. I think I'm happy to just pull the wire in. And I really don't think we're going to close this hole. Just keep. No, this is fine, single wire. But we do want to show you how we're going to close the hole. As you notice, we have no arterial line in the groin. It's only a single venous puncture. I heard that one of the speakers was mentioning that, which is correct. That we don't usually, there's no arterial, so the bleeding risk is very low, complication rate is very low. We have a patient whose EF is less than 10%, less than 20%, and he doesn't need an impella, no balloon pump support, nothing. That's the size of the hole, and we think it's small enough that we don't need to close it. So we're going to show you, can you focus on the groin? We do a single per close. And can you show a little bit more, magnify on the screen? That's great. And then I'm just going to pull this 24 sheet, this is 24 French, by the way, outside the groin now. And Tarun is just putting a single per close in the groin, and usually that's all that is needed. One single per close, and sometimes we put a figure of 8 suture on the groin. Patients usually sit up in 4 hours. We do not send the patients to the intensive care unit because they are better than what they came in. So they usually we're sent to the floor in a telemetry place. And all that we monitor is, there's no bleeding, as you can see, in this entire procedure. So we only check the creatinine the next morning. We don't need any contrast. There is no contrast. There's minimum blood loss. So these are the attributes of this procedure that makes it a safe procedure in a patient who is in such a critical situation. And now under anesthesia, his pressure has gone up, so I'm sure when he wakes up, his pressure is going to be better, and that will allow him to tolerate more afterload reduction, which is going to be better for his heart. Any other questions?
Saibal, would you agree echo is king for this interventional procedure?
Moody, can you show Moody's face? Somebody come this side.
Okay.
Let me introduce you to Dr. Moody Makar, who's actually a cardiac anesthesiologist.
I am
And he's
hooked
one of
up
the
here.
national proctors for mitral procedure. As you saw today, we could not have done a single movement without echocardiography. This is the most appropriate therapy that you are showing in an echo conference because this is truly an echo-guided procedure. I think the role of echocardiography is 70%, and the role of the interventionist cardiologist is only 40%. But there is a very important part of the interventional cardiologist because the interventional cardiologist should know echo very well. We have a tendency that a lot of interventional cardiologists don't understand transcatheter echo in detail. That's Moody Bakar. He's actually the cardiac anesthesiologist who did an outstanding procedure doing anesthesia. So going back, both the interventionist and the echocardiographer need to know the procedure equally well. So I don't know whether we have too much more time left. If there are any more questions that you want to ask me.
One question. My name is Samir Srivastava, Saibal. Hi.
Hi, Samir.
It refutes an intuitive physiology that your LV volumes are reducing, your cardiac output is increasing, but ejection fraction remains the same.
Well, because remember, if your end diastolic volume goes down and your end systolic volume also goes down proportionately, or the end diastolic goes down, you may not show a significant change in the number in ejection fraction. That's what I've seen. But the thing is, if your end diastolic volume goes down and size goes down, what happens is the wall stress goes down, right? And wall stress is the most sensitive marker of afterload on the ventricle. So that's why we always don't see a change. But we have seen very nice things is that unlike in cardiac surgery, where in patients with low ejection fractions, they actually have a dramatic reduction of ejection fraction after surgery, we don't see that with mitral procedure. You can see this patient has remained stable. His heart rate has remained stable, the blood pressure has remained stable. We are on no inotropes. Are you on any inotropes at all? Nothing, no inotropes.
Saibal, I'm Dr. Chopra. I have just one question. You mentioned that after the procedure is over, we do serum creatinine. Most of the patients are having underlying CKD, or they're elderly patient, they already have a comorbidity. I just like to know from you, after the procedure, the immediate comorbidity or the late comorbidity, does it really enhance in the follow-up? What's your impression about it? Comorbidity pertaining to the renal functions.
Yes, we have a study done where we've shown that following a mitral procedure, unlike, as you know, in TAVR, because of contrast and other vascular issues, you actually have a worsening in the renal function, right? Slight worsening. We see a very low percentage of patients who have renal dysfunction or worsening of renal failure after the mitral. In fact, we've shown patients where the renal function is actually improved because of the increase in forward cardiac, especially in in this category of patients, not in DMR, in functional MR. Any other questions?
Finally, Dr. Saibal, still
Yes.
are you a eligible bachelor?
Well, I work all day and night, so I'm still a little bachelor. I don't know that I'm eligible anymore, but I'm just a bachelor. I think I'm a spent force. So, Amuthan, for those who don't know in the audience, Amuthan was my senior resident. He was senior to me in cardiology when I was doing my DM in PGI Chandigarh. So, Amuthan, it's a pleasure talking to you, and it's been an honor to be presenting in your conference. I'm really honored. And I want to acknowledge a lot of people in this room in person because I couldn't introduce. Again, Dave Lange on my left side, he's an interventional fellow. Tarun, he's actually from Delhi. He's an amazing interventionist and an amazing academic, and he's hopefully one day going to go back to India and teach people there. And these are the great guys. Can you come here, guys? Adam, there are 3 people from the company, which is very important. I want to introduce you. This is a very difficult procedure, and you really need the help of the clinical specialists of the company. They're actually, you can see that Nate, Adam, and Colin behind. Colin, don't feel shy. And they are always there, and they really help a lot of physicians. I'm sure people know that. Yoshi's a fellow from Japan. Moody was a cardiac anesthesiologist, and Chris is from Thailand. So we have a multicultural team. And then we have Primal sitting down there, and Alyssa, who's still single and is looking for an Asian man. Okay? And where's Hannah? Oh, yes, Hannah. I'm sorry, Hannah. Oh, Hannah, come here. Hannah, sorry, Hannah, I missed you. Hannah he had a hot date tonight, but because of this case, she actually stayed back. So she left her boyfriend alone. Hannah, say hi. So any other questions? If not, we'll say thank you.
Thank you, Dr. Saibal. Let us give a big